Hi, good evening. Dr. Philip Macmillan. Sorry for the thing moving around, but I'm here to talk about a topic that, for some reason, is controversial, and I'm not quite sure why. Don't know what the politics is. I have some ideas around why it is, but I don't think that's what I want to focus on. But we have today as being a unique and important day in that it is Long COVID Awareness Day, the 15th of March. And as part of my scientific journey and responsibility, I think it's important to talk about long COVID. Now, what I've realized is that quite a number of people who certainly follow me don't seem to think this is a real disease. And they can get quite upset talking about long COVID. Well, anybody who has followed me should know I don't believe in ideology. I just look at science. And if a patient or a number of patients are unwell because of something related to an infection, post viral syndrome, some people call it, then we need to understand it clinically and we need to understand what we can do about it. That's where my interest in COVID, when I looked at autoimmunity, and long COVID, because it's relevant, it's important, and it's important to patients. So I don't like the politics of the fact that some people say it doesn't exist when they haven't researched it. And I can tell you categorically anyone who says it is not real has not done any research. I will say that categorically because I know that if you do even a little bit of research, you'll realize that there is a lot of information out there that we don't fully understand. And we can see that it is tied to a spectrum of disease. And this is the important bit. The reason long COVID has caused a problem is because we didn't adequately investigate post viral diseases. So you had things as well, even Lyme disease, chronic Lyme disease. We didn't investigate it properly. MECFS, we didn't, which is chronic fatigue syndrome. We didn't investigate that properly, and so therefore, this is all on the same spectrum. Similarly, fibromyalgia. So it's no surprise that the scientific community is playing catch up on this, and maybe there's a bit of embarrassment that they don't fully understand is around the fact that the research wasn't done. So we are trying to catch up on 30 years of poor research in a very short period of time. And I learned very quickly that this is far more complex than even I had thought. So, what I'll be doing today is that I'm going to be going through this, what I thought was a very interesting paper, Muscle Abnormalities Worsen After Post-Exertional Malaise in Long COVID. And the purpose of that here is to try and understand a little bit more about the disease. This is January 2024, so it's relatively recent. Before I go into it, I just wanted to encourage you for those people who are interested in long COVID. And it's so fascinating that I had to do this split. I have two separate Substacks. One where I talk about COVID and the research and the challenges about what's happening with longer term disease and excess deaths. One part of my subscriber followers can acknowledge and accept that. But when it comes to long COVID, some of them can't. It's really fascinating. And I instinctively knew to separate the two. So there is a separate Substack that I have that is purely about long COVID. And in there, you can see this has been going back for almost 2 years of me capturing research, capturing thoughts, interviews, breaking down analysis, trying to make sense of what really is a very, very complex disease. So the link is there for those people who are interested in understanding more about my research into long COVID. Sadly, it is not over because this is a complex disease. Here are some basic premises, and this was taken from a paper by Eric Topol and Ali Ziad. And they pointed out that there are many forms of long COVID. And this is part of why it's so complex. It's multisystemic, it affects multiple organ systems. They think that there is viral persistence. I would argue that it is viral persistence of protein, not active virus. Immune dysregulation. This is what I thought it was when I started the research. I thought it was just autoimmunity. Turns out it's not that straightforward. This is huge, microbiome dysbiosis. And I think that this is probably going to turn out to be the most significant part of long COVID. The endothelial inflammation and microclots, I think, is going to be part of the disease, but not the primary pathophysiology. Again, neuronal inflammation is again is a symptom of what is going on, but not the pathology. Mitochondrial dysfunction is another thing that they have found that was also present in MECFS chronic fatigue syndrome, seems to be part of what is happening with long COVID as well. So, one of the questions would be, as I look through some of the statements that were being said today on social media about long COVID, is that when people raised it, there was certainly a cohort of people who were absolutely hammering it down. Doesn't exist. It's in people's heads. They just want people to be sorry for them, I guess. I don't know about anybody else, but I don't usually like to label stuff as being in people's heads unless I have excluded all the possibilities. And in the case of long COVID, if you've done the research, you realize this is quite complex. But what I was surprised about that even at a governmental level, and I saw something from Australia, which was saying that this is just post-viral illness, nothing separate, different from what could happen with the flu. And when I saw that, I thought, why is that now suddenly being de-escalated? Well, here's the reason why I think it is, and this is very, very important. So, what I'm going to say here may upset both sides of the fence because this is just what my research is showing. Here is what we have. I think long COVID, they were right, is probably too simplistic a term. You have damage from severe COVID 19. People can have lung, heart, brain, kidney damage. I don't actually consider that to be long COVID. That's just the sequela of severe COVID 19. And I don't think it should be included. Confuses the picture. This is more likely to be long COVID, where you have Epstein Barr reactivation, you have the microclots, you have gut dysbiosis, as we had seen before. And this is what I'd call as the pure long COVID. This is what happened before 2021. What's causing the problem is the fact that you have, I think, non infectious spike protein complications. That's as politically correct I can put it, where what we have is that the spike protein from other sources drive autoimmune responses and drive reactivation of latent viruses and infections, and then exacerbate the whole picture. One of the problems that we have is that the strangest thing about it is once I saw that there were some people who could get long COVID just from being vaccinated, I realized that has to be critical in understanding the pathophysiology. On the other side, you have some people whose symptoms improve after vaccination. So, therefore, there is certainly an immune component, but it's not clear exactly how it fits in. What clearly is a problem is that most don't want to acknowledge this part of the involvement. And if there's no acknowledgement of that, you're not going to get to any solutions. So I'd advise the long COVID community, don't ignore this. Get your head around it because, in truth, if you had long COVID, you may have found that your symptoms worsened when you had further spike protein. You need to acknowledge that, you need to understand it, and recognize it could have complicated the picture. That's the truth. And so, because there's so much politics around it, it makes it very difficult to make sense. That's the point that I'm starting at. And as I said, if you want to join me on this long COVID journey here, please click on the link. This is my Substack. It's been going on for about 2 years now. and you can join in this journey for long COVID. So that's the first part of what I'm talking about. If you're watching this live, you will be able to see my presentation or when I analyze the paper. If you're not watching it live, you'll have to go to the Substack to see it afterwards. So thank you for the people who are with me now, and I hope that you find this interesting. So let's get to the science. Here we have a very, very interesting paper, and this is about muscle abnormalities worsen after post-exertional malaise in long COVID, published in January of 2024. So I think that this is an absolutely critical paper. And they were looking at trying to understand what happens to long COVID patients after they have done some degree of exertion. So I've got the PDF here and I'm going to go through it sequentially because I think it's a very important piece of work. So as I go down, the first thing that stood out to me is when they broke down the table of the participants. This was done in Amsterdam, and they put them on a bike, made them exert themselves, and looked at all of the changes that occurred. When they looked at the participants here, they had 21 healthy controls and 25 people with long COVID. They looked at the ages, 42 and 41, so they were well matched. Largely male, it's well split, so 12 males, 13 females, and so on. So well balanced. Look at it. Now, this is the bit that I want you to look at carefully here. Um, What's interesting here as well is all of these were fully vaccinated. This is why I said that you can get a complicated picture when you don't understand that vaccination can, in and of itself, change the trajectory of the disease. Here is where you have an interesting thing. When you looked at the weekly working hours, 36 hours, this was pre infection. Post infection, you have weekly working hours in the healthy controls remains at 36, drop down to 5 in long COVID. Now, I'll tell you this much. Just look carefully at their age. 41, prime of their life, likely having young families. This is when they're accelerating in their career. They can only work 5 hours a week. Anyone who looks at that and thinks that somebody is just doing that in their head has got to themselves have a problem in their head. People don't do that. That is significant, to have that much of a reduction in your capability is absolutely incredible. And so when we look at what they did, as I said, they did do an exercise. They went on bikes, worked out for a period of time, and then they tried to work out the differences between the cohorts. This one here is looking at the amount of oxygen extracted mils per minute. And in white is the healthy control, and in red is the long COVID patients. So, one of the things that is fascinating again is that it's clear that the long COVID patients are not able to extract the same amount of oxygen when doing the same amount of work compared to a healthy control. So, it's no surprise that they have a degree of fatigue, and this is a significant percentage drop. In terms of the peak power output as well, it's lower in the long COVID cohort. Gas exchange is lower in the long COVID cohort. And you can see as well the relative work rate, their capability, these are the red dots, are lower across the board in the long COVID cohort. And this is therefore very, very significant. So, one of the critical features of long COVID is to do with the fact that they have this fatigue and the post exertional fatigue, what we call PEM, where they literally crash after they have done any kind of exertion. And when you look at what happens from a scientific point of view, this fits with the science. Here is another important point, and this was in the paper here. I just highlighted it here. Um, this is talking about succinate dehydrogenase activity. and this is talking about mitochondrial function. It was not reduced in the healthy controls 1 day after exercise, but was reduced in the long COVID patients, suggesting that the combination of reduced maximal mitochondrial respiration and decreased mitochondrial content are part of the pathophysiology of post exertional malaise. There is a problem with the capability of the body of long COVIDs to use oxygen and to break it down to energy. And this seems to be really fundamental to understanding what is going on with the disease. As I said, you just have, you're talking about 10 to 15% reduction in the energy output capability in any organ that is going to cause symptoms. But certainly in terms of mobility, they'll not be able to run as far and they'll probably have more symptoms afterwards. And it certainly would have an impact on the brain because the brain uses the highest amount of energy for the size per gram of tissue than any other organ. Here again is another bit that I've highlighted here is that what they found is from the analysis they conclude that the Krebs cycle metabolites, and I'll show you this in a little bit, were lower in skeletal muscle and blood in long COVID patients, but did not change during post exertional malaise. This is talking about the function, the actual amount of energy being produced at the cellular level was clearly lower in the long COVID group than they are in normal healthy controls. So it is no surprise that they have symptoms. And as I said, the science is there. Our problem is that we don't quite understand why these things are occurring and how do we fix it. And part of the reason I think that people are getting frustrated, and I know that frustration because there's nothing worse than trying to help a patient who isn't getting better. It's difficult. It's not a nice, pleasant feeling, but you have to work at it. And this is the challenge that we face with regards to long COVID patients. Here is another bit of research that they did. They then took muscle biopsies. So they took samples of the muscle. This here is the healthy, and these are the capillaries. This here is long COVID. And what they found in this was that they found that the muscle capillaries, there were no differences in capillary density or the capillary fiber ratio, but they found that the ability of the long COVID patients to extract oxygen from it was decreased. So, even right in the context of the cellular use, so they can see here capillary density and the amount of capillaries is about the same, but the capillary to fiber, muscle fiber ratio is lower in long COVID patients. That doesn't happen overnight. So this is something that is ongoing. And when we looked at the time frame, I think I'll have to go back to this because this was such an important point. I'm going to show you the time frame here as well. So when you look at this here, I'll go back to the table. The time since initial SARS-CoV-2 infection here you're looking at in healthy controls was 142. In the long COVID patient, they were still having symptoms up to 545 days after having had exposure. This is a really long term issue that is going on. And so, this is why I said when we look at the images and see that the capillary ratios are changed, that is an indication as to how long this has been going on. Going back again, um, they really then broke it down when they did the biopsies. So this is why I said the science is there. We're just trying to interpret it. What does it mean? But it's clearly showing some really profound abnormalities. And again, they were looking at the different types of muscle fibers type 1 versus type 2A versus type 2A and 3. And then this is another type. They're higher is type 1 and type 2A than the healthy controls here. higher as well. Type 2X is higher here. But for the other ones, just type 2A fibers are much lower than the healthy controls. And the type 1 are again lower. So the whole muscle morphology in these patients is changing. This is pretty serious stuff. What is it? As I said, the challenge is trying to figure out why is this occurring. My rule is that there has to be a primary pathophysiology. There has to be a central problem that is causing all of these things. So again, going back to another thing that they looked at when they were doing the muscle biopsies, they looked at this interesting question that I was following: exercise induced amyloid containing deposit accumulation in skeletal muscle. And what they were looking at, they were hypothesizing that amyloid containing deposits in the circulation can block perfusion of blood vessels, causing injury. Now, this is important because this is what we've been talking about in the context of microclots. So I've been looking at microclots and looking at the embalmer's clots and trying to tie the two things together. They're clearly seeing here in long COVID patients that there is a higher circulation of these amyloid fibrin microclots. And critically, they're finding that the deposition in skeletal muscle also seems to be higher than normal. And you can see here that they demonstrated that the concentration of amyloid containing deposits was greater in the skeletal muscle of long COVID patients at baseline and increased in both groups after the induction of post-exertional malaise, but it was higher even at baseline in terms of the long COVID cohort. So these are very hard pathological findings that makes you know that there is something quite serious going on here that we need to try and see if we can break down. We're now going into the other part of the paper where they're looking at the function of the muscle and the mitochondria. And here you have a situation where they're looking at the capacity, the oxygen capacity, comparing the healthy controls in white, the long COVIDs here in red, and you can see their oxygen capacity is significantly lower, especially a day after they did exertion. So this is what they did at baseline. It was lower, but actually look at this. It has gone down, but not as significantly. It was low before, but still went down a day after they did their long COVID, their exercise, their exertion. This here enzyme, succinate dehydrogenase, is looking at the function of this enzyme in the mitochondria. And what's interesting here is that at baseline, the long COVID patients are about equivalent as the healthy controls. But a day after, this has fallen in the long COVID cohort and increased in the healthy control. So this is the recovery phase when the muscles need to recover, they need more energy. In this case here, after long COVID, they don't have the energy to get to the recovery. And it could explain that critical thing about the post exertional fatigue that they have. It's really fascinating. It literally is, they can do exertion in their daily activity. They could say, take a jog out to the street. So they are not tired in the moment of doing the jog. But when they reach back, they feel shattered. And that feeling continues into the next day and sometimes for days afterwards. It's a very, very unusual pattern. But when you look at the metabolic pathways, it starts to try and make sense. So I'm still trying to work through it. I'm just showing you some of the thoughts that I have. Now, this part here is showing you what happens within the cells themselves. Okay, so I'm just going to try and see. So let's look at muscle metabolism in long COVID compared to healthy. I'll try and see if I can help to break down what it is. They are first looking, this circle here is representative of the top half is the baseline, the bottom half is one day after they have done exertion. If it's higher than normal, it starts to go red. If it's lower than normal, it starts to go towards blue. Okay. So as you go here, and I think I'll have to zoom in some more on this. So yes, I think this is worth it. This is working now. So here you have at baseline, interestingly, the glucose level in long COVID seems to be higher, but it's about normal after exertion. This is down to the whole pathway. So this is how the body breaks down glucose, and you can see the full pathway here down to pyruvate. Takes all these steps. It does make some energy here, but this the main source of energy comes when it goes into the mitochondria. But even looking at this breakdown here, you can see some unusual patterns. Slightly higher fructose 1,6 biphosphatase is here. The DHAP is higher and then drops quite low after exertion. I think I'm going to have to look at this one. This is very interesting as to why this would occur. Pyruvate is low before and after. So, what it suggests is that this pathway is diverting, and this is what seems as though it's happening. It's diverting into the synthesis of purine rather than into making energy. And you can see here that for quite a lot of these here, the amount is low at the beginning and then gets lower. Look at what happens with uric acid. It really is low before and gets really low one day after. So it seems that the metabolic pathway is diverting a lot of the glucose molecules down here. Again, you really have to sit down and try and tease it out to try and make sense of it. But it is clearly very, very relevant. And again, here, this is now going down to the mitochondrial level. You can see here, this is the mitochondria. So this is where most of the energy is produced. So one molecule of glucose will produce about 38 bits of adenosine triphosphate. And most of that occurs, over about 30 of it occurs down here. So usually when people are exerting themselves too hard and they can't get enough oxygen, this is where the body uses this pathway to get to pyruvate, then to lactate to make energy. But this part is the efficient bit. What you can see is that even the starting point is low in the mitochondria. And you can see this is the TCA cycle or the Krebs cycle. All of these are low in the mitochondria all the way through. Nothing is elevated. And this is suggestive that it may not be a problem with the mitochondria. It may be a problem that the mitochondria cannot get the resources it needs to make energy. And as I said, I'm going through the paper now to make sense of it. You know, it really is some important stuff to try and tease out. And when we look at what happens in blood, so I shifted across in this one here. So to the left here was what happens in the muscle. This one here is what they found in the bloodstream. And again, this here is largely been low. Let me just make it full screen. But again, one of the things that stands out here is that this GDP gets very high within the mitochondria or in the blood when it's measured. So there are some differences between what is occurring in the muscle and opposed to what is occurring in the blood. And trying to tease out how they interact is going to be absolutely critical to trying on to understand what is going on in this very, very complex disease. So as I said, it's critical to try and see if we can make sense of what is going on. But understanding exactly what it means is still a work in progress. Here is where I've captured a few other bits that I think that were interesting. A low exercise capacity is one of the hallmark signs of long COVID, associated with a substantial burden for daily life. The ventilatory and central cardiovascular system did not limit exercise capacity in long COVID patients, but our results confirm previous suggestions of a peripheral impairment in skeletal muscle metabolism in long COVID patients. So, this seems to be a critical part of what is going on. And so, it's just that the body is unable to efficiently use oxygen to make energy. And it's no surprise, therefore, because if this is occurring in skeletal muscle, we can't do a biopsy of the brain. But I suspect that if we did do a biopsy of the brain, we would see a similar pattern with mitochondrial use. And this would then explain all of the characteristics of the brain fog and so on. Here's an interesting and important point. What happens when the elderly get long COVID? You can't tell the difference because they're already fatigued. They already may have some cognitive impairment. It will just get worse. And so one of the really important issues is that the elderly cohort is at very high risk for deterioration if this kind of pattern is also occurring in them. And some estimates it's almost 12% of over 75s. So if you have a grandparent or a mom or dad, depending on your age, these are really important points to try and look out for. Here is another bit here I highlighted. We found an impaired peripheral oxygen extraction and relatively lower deoxygenation and a higher concentration of amyloid containing deposits in skeletal muscle. We did not find evidence of blocked capillaries within the skeletal muscle. So one of the issues that we've been worried about is it that these microclots block the blood vessels and this is what's causing it? It doesn't seem to be that's the case. Now, the microclots are probably still having an effect, but not necessarily what we thought would be necessarily the characteristic that we would have thought. Again, now, going to the science, and for those who, as I said, want to understand the science, this is some really hard pathological evidence that there's something very unusual going on in these patients. But as I said, for people who don't want to bother looking at the science, it's easy to just label it as in people's heads. Those who are watching this, remember, just think about something, an important point. If you don't know anybody with long COVID, it probably means that they don't feel comfortable to share their struggles with you because you are likely to know a number of people who are struggling with it, but they feel self conscious about mentioning it because people just tell them, come on, just get on with it. Don't worry about it. You'll get over it. That is not helpful. And rather than going through the annoyance of telling you, they will just not share it. And so you have to think carefully. If you don't know a few people with it, it's because they don't feel comfortable to tell you. Just a point to reflect on. Here is some of the muscle abnormalities that you will see in terms of the long COVID and healthy control. And you can see here again, this is looking at atrophy, whether or not there is atrophy of muscles. And you can see in the long COVID group, it is significantly higher than the healthy control. Again, this is fascinating. Necrosis, actual damage to the tissue, is significantly higher, certainly a day after they have done an exertion. It's important to know that you normally have some degree of damage when you exert yourself, especially when you put muscles under stress, but it is way higher in the long COVID group. Regeneration is still occurring, and that's a good sign. And in terms of the internal nuclei, it seemed again higher in the long COVID group. So, this is what I'm saying. This is some hard pathological evidence that there is actual real damage occurring in the context of long COVID. When they looked at one of the interesting things that they did, I'm not sure why they did this. They went looking for capsid protein, which is what you would find if you had an infection. And they found it in both healthy and long COVID. What I would have wanted them to do is look at spike protein. What's the deposition of spike protein, long COVID patients versus healthy? I am not sure why they didn't do that. That would have really been valuable to try and work out. And maybe they have, maybe I just haven't looked in enough detail. But it certainly, in my mind, would be a really important thing that they could have done. I'm looking to see if there is any other point that I want to highlight about this. And just again now, to pull this back into context, just now think about what I've said with regards to mitochondrial dysfunction. Suddenly, when you think about that, you then realize why people have neurological symptoms, because they're not able to extract the same amount of oxygen as the other person. And it means when they actually try and do anything that requires higher concentration, they will definitely struggle. Similarly, with regards to cardiovascular symptoms, if the heart is put under strain, it is not able to extract as much oxygen, and therefore you're likely to have more unusual rhythms that can occur. The metabolic symptoms, again, the body has to compensate. And so it's no surprise that you see issues around lipids and diabetic control. All of these things seem and potentially could stem from the mitochondrial dysfunction. So here is my final thought on it. I always believe that there is a primary pathophysiology. I still don't accept that you ever have a disease where there are 10 things happening. There's usually one primary problem. If you can find that primary problem, it can cause 10 different things to occur, which then cause 20 different symptoms. But you have to understand the primary problem. The thing that has puzzled me most about long COVID is the fact that patients oftentimes are stable with their being unwell. In most instances, even if you had a post viral thing or post viral Lyme, a lot of people, they're bad first and then they gradually get better. This is not the case for all long COVID patients. No, it's not that none get better, but there's a cohort of them who are just flat. They are not getting worse, but they're not getting better. There has to therefore be a driver that is consistent. And that's where, in my view, and this is what I'll be looking at in much more detail here, in my view, I think that this is going to be the answer. Dysbiosis with regards to the microbiome, because we only think about it in relation to the gut. But what happens if this dysbiosis is also occurring in the upper airway, in the epipharynx, because that's one of the things that's very consistent in long COVID, epipharyngeal inflammation. I didn't go into that at the moment, but you can look at the course on my Substack to be able to hear some more about that. But the point is that inflammation in particular parts of the body seem to drive these patterns, and the inflammation around infection, chronic infection, microbiome dysfunction could be the answer to what we are facing. So, thank you for those who have joined me. And just remember, on Long COVID Awareness Day, I would advise you to reach out to people and see who is struggling with it. Who do you know who may be having long COVID and doesn't feel comfortable to talk about it? They just need people to listen to them. Can you imagine having a toothache that everyone ignored, where they said it's not real because they can't see any evidence of it? We have a condition called trigeminal neuralgia, which is associated with incredible pain to the face. There are no obvious symptoms of it. There's nothing you would see, but the person is in intractable pain. Can you imagine if the medical community ignored them because we can't see an obvious problem? Imagine how they would feel if you, families, and friends discounted it because you can't see an obvious problem. That's where we are with long COVID. And I'd encourage everyone, if you're interested in science, please remember join me on the Substack. I will continue to expand those thoughts. And you can see here one of the most recent ones that I did was around long COVID and iron deficiency. And so you just join. I'm happy to take on any discussions to understand a little bit more about what people are feeling and thinking. And I am determined that at the end, we should be able to find an answer for this. So this is the Substack. And as I said, this one here, epipharyngeal inflammation and the PET scan, this is a really interesting presentation on that. And just looking through all of the aspects of the disease is actually very, very important and very, very valuable. So thank you very much again for being with me. Have a great evening. For those who weren't on the live, please click on the link below to go to the Substack. That's where you can see the full presentation. It will be freely available, and we'd be happy to have you join our research journey. Have a great evening.